I work mostly with federally qualified health centers and other grantees. I've done that for a long time. I cannot remember an instance where I have knowledge that a health center is misusing its savings.
What restrictions around contract pharmacies and manufacturers' policies and what that looks like specifically for health centers on the ground?
I think the rebate model pilot program is so significant because it is changing the way covered entities participate in the 340B program.
Hi everyone, I'm Amanda Pears Kelly, the CEO of Advocates for Community Health, and welcome to Community Health Centers Unfiltered. Today we're tackling one of the most consequential and often misunderstood programs in the health center world, 340B. The past year has brought a wave of federal, state, and private market changes that are reshaping how community health centers and Ryan White clinics operate. These changes affect everything from revenue to patient services, and the impacts are showing up on the front lines every day. Joining me for this conversation is Daphne Kackloudis. She's counsel to CHCs and Ryan White clinics who brings firsthand insight into the legal and regulatory shifts driving these changes. Together, we're going to unpack what's happening, why it matters, and how clinics are adapting to ensure patients continue receiving the care that they need. I'm happy to get into it. Here we go. Hi, Daphne. It's really good to be with you today. I'm really excited for our conversation. To get us started, can you just please introduce yourself and tell us a little bit about your work?
My name is Daphne Kackloudis. I'm a healthcare lawyer by trade. I've spent really all of my professional career sort of at the nexus of healthcare public policy and sort of traditional healthcare regulatory and compliance legal work. I also spent a good number of years working inside a community health center, a large federally qualified health center here in Columbus, Ohio, which is where I'm sitting. And in my career as sort of advisor and advocate, I also represent federally qualified health centers and other types of healthcare providers, actually a pretty diverse range of healthcare providers in their, sort of daily business operations. And I like to think of myself as an extension of my clients' leadership team or business team. Most of my clients, I think all my clients but one are nonprofits. Most don't have in-house lawyers. And I really feel oftentimes like I don't even function as much of a lawyer as I do as just sort of like a sounding board and, a person assigned various and sundry other tasks, which I love. I love that I have a diverse practice area and I get to sort of be inside health centers and other healthcare providers and advise them from the inside out and sometimes from the outside in.
I love it. Well, thank you, because there is not a shortage of things to work on in this space that we're going to speak to, which in particular is sort of 340B Unfiltered. So one of the questions I had to just get us started is that there have been so many changes to the 340B program, and given your work with health centers and with Ryan White clinics, can you just maybe pick out from your perspective the biggest changes that we've seen from sort of the federal, state, and the local level, sort of what that looks like?
Yeah. In preparing for a conversation, I thought about this, and first I jotted down the 340B rebate model pilot program, and then I jotted down state legislation to protect covered entities. And I think those are still the top two sort of most significant changes in the last year. If we look back further, of course, we can't ignore the manufacturer changes, manufacturer restrictions, drug manufacturer restrictions placed on covered entities. So that's kind of, an ongoing significant operational challenge to health centers. And I know we'll talk a little bit more about that later. So that kind of persists, and that's just sort of, become the new normal. Dealing with that has become the new normal. And then you layer on top of those already significant challenges, preparation for the rebate model pilot program, and then opportunities at the state level and of course the federal level as well to implement legislation aimed to, well, I guess it depends on sort of what we're talking about or where we're looking. In some instances meant to protect covered entities, and in some instances meant to do other things, particularly at the federal level. I think the rebate model pilot program is so significant because it is changing the way covered entities participate in the 340B program it is likely to have a negative financial impact to them for reasons we can talk about. It's creating tons of administrative burden to them. And actually, talk about timely, just yesterday, I don't know if you saw, that the American Hospital Association sued HHS to block, they're calling unlawful 340B changes, which is directly aimed at the rebate model. So happy to talk more about that if you're interested. I mean, I could probably talk for days about the rebate model, why covered entities are finding it problematic, and what it might mean for covered entities and other stakeholders sort of in the 340B process.
So I would like to talk more about that. I did see it just yesterday, timely, always. As a precursor to that piece, though, I'd love if you could, and it's speculatory or I know it's perspective based, but what do you think is driving this? Like, what do you think is the reasoning behind some of these changes? Kind of pro and con, obviously, but from your perspective in doing all this work, like what's the greatest wisdom that you can share in terms of what the lens is on the why behind some of these things?
Yeah, I think answering the why depends on whose shoes you're standing in. I think regulators or policymakers, lawmakers, particularly at the federal level, have been pretty clear that some of them have been pretty clear that they have an interest in better regulating the program. A lot of the program has been operationalized over time through agency guidance or frankly just, grant requirements, but just sort of best practices. And, I know from my work with many, many grantees, so different types of 340B covered entities, I know that the vast majority of those entities work tirelessly to ensure they are, abiding by the terms of the program. I'm sure there are bad actors out there, just like there are probably in any program. I've not encountered one, but that doesn't mean they're not out there. So I think there certainly is a desire by some policymakers to implement a more official, I guess, sort of regulatory framework to memorialize in legislation some programmatic boundaries that a lot of covered entities probably already feel like they're doing. So that, I think, is perhaps a motivation by some of the policymakers. The drug manufacturers, I believe, want to protect their bottom line. When I think about sort of the tension between covered entities and drug manufacturers, it really is singularly about the money. Which party, which entity is retaining the 340B savings? The covered entities, by law, have the ability to participate in the 340B program. They're required to take their savings, reinvest it in their programs to, stretch scarce federal resources. Of course, you can't listen to a 340B podcast without hearing that catchphrase. And the drug manufacturers, I believe, to the extent that they're looking for legislation that squeezes the covered entities, are motivated by a desire to make it harder for covered entities to participate in the program.
I think one of the unfortunate realities that comes up a lot in conversations, frankly, across the spaces, certainly when we're talking with policymakers and even, to be honest with you, sometimes with the, manufacturers. Health centers in particular are such a small percentage, as we're talking 5% of the overall. And so, and something that you said that I want to pull out, that, a lot of from an accountability perspective, sort of like the tracking and the desire for greater transparency, a lot of that is already happening. Certainly within the walls of health centers, like they have to account for every dollar through their system. Have they been, super rigid about this dollar came from 340B and this dollar came from Medicaid reimbursement? Maybe not, but they can still track and demonstrate how every single dollar is going back into patient access, into mission, into solvency in order to fulfill. And so it's been challenging and frustrating, I guess I would say, to see some of the policy changes, but also just the erosion of the program for knowing that, where it's sort of like, okay, we're not necessarily viewed as the primary issue here. We're actually pretty much aligned with what is being sought after from a policy perspective, from a regulatory perspective. And yet, some of the changes are so incredibly harmful and damaging. And I think the rebate model, there's a lot of concern about what that's going to look like. As you said, from, the administrative burden that comes out of it, the fact that a lot of organizations just don't have the dollars to put up front in the first place. I mean, I've heard from some health centers that they will probably back out of the program entirely. I've heard from others that the cost in order to make sure they can stay on top of things is prohibitive, or that they'll have to dial things back considerably. I've also heard, and this is, interesting, and we don't need to get into the weeds of it, but I've also heard that, the health center is very likely in certain circumstances to write the script, but not to carry it. And so that then looks like the patient going down the street to the hospital pharmacy, basically, because they're the only ones that are going to be able to cover the costs, which sort of seems to defeat the purpose of what is intended with the model. But let's get into, what came out yesterday. I do think that that's relevant, and maybe you could just paint the picture of, what that means and what the, sort of the strategy around, okay, if there's success with that, what does that mean for everybody else? What does the timing look like? Because, we're up against a wall. It's January 1 is when this takes effect. And so, the last piece I'll say, and turn it back over to you, is that we have heard, from HRSA and others that it is a pilot, and so it isn't permanent. It is a test, it's a trial. And so if it doesn't go well, then we have an opportunity to change things. I think the worry that I have is that what is to be lost in the process of what's being rolled out. And if there are some health centers who literally will end up closing doors because they can't, I'm not sure that's reversible. But let me turn it back to you in terms of, what came out yesterday and just sort of what do you think comes next?
Yeah. And to pick up on one of your last points that HRSA, is saying that this is a pilot, and that if it doesn't work well, or, we learn things in the process that clearly indicate that it's not a beneficial process for covered entities or patients, that, perhaps they'll change it or go back to sort of business as usual. I can imagine if you're a covered entity, if I'm sitting, in their seat, it's hard for them to sort of put their eggs in that basket, because the same people really, frankly, rush the process. And that's what the American Hospital Association is arguing, or did argue, in its bid to secure a temporary restraining order. Their main point is that the process was so rushed and didn't really comply with the appropriate administrative processes, that stakeholders didn't have enough time to, sort of get their systems in place to ensure that they can comply, that they can even do this. Yeah. And to your point, if they can't participate in the process the way that, HRSA is now saying that the process is going to operate for just, a certain number of drugs and manufacturers, then they will perhaps suffer irreparable financial harm. Yep. And so AHA's lawsuit is really meant to just sort of halt the process, at least for now, while things can get sorted out. If they're successful, that's a good thing for covered entities. I think that will, either allow time for the process to play out, or perhaps for the parties to seek a more permanent solution, which is perhaps rolling back the pilot itself. And if AHA is not successful, then, we have less than a month for covered entities to prepare to participate in this business process that is completely different than anything they've been doing. I read actually a really good article the other day. I can't remember the publication, but if it comes to me, I'll certainly mention the name of the organization. But the takeaway from the article is that the rebate model is one more administrative burden on covered entities that have had to invest, in their workforce, in hiring people like me to help them navigate the process, and consultants and other third-party administrators, just to maintain their operations in the 340B program. And this particular article I read did a really good job of naming like essentially 6 different business pathways that a covered entity has to use in order to participate in the 340B program. So if it's participating in the ESP, platform, then it has to use that platform. So it has to have a person or people who understand sort of how to submit data using it. There's now a competitor to the ESP platform. So if a manufacturer requires use of that platform, then you need a person who can, who's familiar with that pathway. The rebate model requires a whole different set of, some of the data is the same, but reporting it is different, and the timeframes are all different for sort of tracking scripts through the process. It doesn't seem probably like administratively that burdensome to comply with all of these various, nuances to the program that are being sort of piled on top by different entities and manufacturers and now HRSA. But it is really costly and administratively very difficult for covered entities to comply. And then sort of to a point you made earlier, best case scenario is a really, a hospital system with lots of revenue streams and, diverse revenue streams and a large workforce that can handle this. Then all the way at the other end of the continuum are grantees that are already struggling. Their workforces have been impacted by a variety of other factors, and they just don't have the person power to do it.
No, they don't. And I mean, honestly, to your point, a lot of health centers don't even necessarily have the resources to be able to hire and engage somebody like you, and I think that's the unfortunate, and a lot of times I say unintended consequences. I'm not sure it's an unintended consequence in this case, but I think you're spot on. It's sort of like the entities, and I'll focus just on health centers, the health centers for whom the program was designed, right? And who have over and over and over again proven in congressional hearing and supplying data and, you name it, proven that the dollars are going back to where they are intended to go, back into the community, into patient access and care. And yet they're being strangled slowly to the point where it's just not, I think the rebate model, unfortunately, for some health centers, not all, I don't think it's sustainable. They may not have the resources to hire somebody in order to manage the additional administrative burden and just the hoops that will have to be jumped through. Two, they may or may not, more than likely, many of them will not have the dollars to put up front in order to cover the reality of what this looks like. And then, I think the other sad thing is that 340B revenue is as important, if not more important, for so many health centers as their grant dollars. And so as this continues to shrink, and you have, uncertainty with the grant funding, which has been flat, if not, reduced at best, plus you have the changes with Medicaid, plus you have workforce challenges. So it's just it's a really gut-wrenching reality right now. But I will say I'm really proud of the work that ACH is doing. I'm very grateful for the work that you're doing. I think that there are a lot of people coalescing around, okay, the issue is not, or no one debates sort of improving the program. I think, and even from a reform perspective where it's like, okay, fine, we want accountability, we need transparency. I think everybody's on board with that. But it can't be done at the cost or the harm of the entities who, again, have validated that they are using it in the way that it was intended. But let's get into, I would love for you to speak to what restrictions around contract pharmacies and manufacturers' policies and what that looks like specifically for health centers on the ground.
Yeah, so I think, if we go all the way back to the late 90s, mid 90s, which seems like another lifetime, but, I lived it, a long time ago, 1996, HRSA sort of issued their initial guidance authorizing covered entities to enter into contract pharmacy arrangements. And then, of course, several years later in 2010, they issued the revised guidance allowing unlimited contract pharmacy arrangements. And it was that guidance that really made it possible for health centers and other grantees to best serve their communities. I think it's common when we're talking about the contract pharmacy, the importance of contract pharmacies to think about, how it's impacting healthcare service delivery in rural areas. But it's not just rural areas, right? I worked at the health center in a major metropolitan area in California for which contract pharmacies are equally important because their patients just aren't going outside of their own neighborhoods to get their medication. So absolutely, yes, the importance of a broad network of contract pharmacies is equally important in rural areas and urban areas alike. Fast forward again another 10 years after HRSA's revised guidance, I think it was all the way back in 2020 when the first drug manufacturer sort of announced its restrictions on 340B in the contract pharmacy setting. And then, all these other dominoes started to fall. Other manufacturers followed suit. And of course, they didn't follow suit necessarily in the same way. So you've got you have sort of a patchwork of manufacturer restrictions dictated by certain drug manufacturers, and I think now we're up to 20 manufacturers that have they're implementing restrictions, maybe more. Some are similar, some are different. It makes it really difficult for the pharmacies for covered entities and their pharmacies to consistently serve their patients. And at the most basic level, when a contract pharmacy goes away in a particular area, those patients have to make a decision. Are they going somewhere else to get their medications? Are they going to invest their own time and resources to go to, the in-house pharmacy, if there is one that the covered entity has? Is that even feasible? And oftentimes, I know this is true, particularly with Ryan White grantees and maybe others as well, but it is, for many patients, the relationship with the pharmacy is more than just, that's where I go to get my medications. That's where I go to get my medications, yes, but that's where I go to get specialty care. That pharmacy is a welcoming, affirming environment where I can get guidance on related conditions. I feel safe there. It is really detrimental to the relationship between the patient and the covered entity and it ultimately results in many instances in the patient provider relationship eroding, such that the patient goes somewhere else, or maybe they stop getting their medications altogether, particularly if they can't get them, and if they can't get them through an entity that makes them affordable for the patient. Yeah. So it's, the impact of the manufacturer restrictions on contract pharmacies, I think, cannot be overstated. And at the beginning, when this first started happening in 2020, I think many health centers were sort of holding out. They were resistant to participating in ESP. I think, concerned about sharing their data and how that data would be used by manufacturers and others. And, anymore, I think, in most instances, they're participating because they prioritize treating their patients over their own concerns.
Oh, there's so much. So I guess all of this related, but what do you think is the most common misperception, in the media and just, in general for lawmakers about how they talk about 340B and sort of understanding about the program in general?
Yeah, it's hard to choose just one. I think the greatest hits of misunderstandings include that covered entities are marking drug prices up, right? They're not doing that. The manufacturers are setting the price. So the covered entities are not marking up drug prices. They're not inflating drug prices. As super popular misunderstanding is that covered entities are misusing 340B savings. Again, to your point, I work mostly with federally qualified health centers and other grantees. I've done that for a long time. I cannot remember an instance where I have knowledge that a health center is misusing its savings. There was, I think I mentioned to you and members of your team when we were preparing last week or the week before that, and actually an article just showed up in the 340B report maybe last week about these sort of dark money groups that have launched a smear campaign against the 340B legislation here in Ohio. When you look at those dark money groups' websites, or when you look at the communications they're sending out, the claims are baseless and totally misleading, including saying things like, federally qualified health centers are using their 340B savings to buy art and maintain, an art gallery in their health center. It's not true. To your point, most health centers, of course, are able to track their revenue, their 340B savings, and these health centers are using their 340B savings appropriately. That one really gets under my skin because it's just, in the vast majority of instances, it's not true. Another misconception is that there's no oversight over the program, right? Covered entities are required to comply with manufacturer audits, HRSA audits. They're required to have detailed policies and procedures. There are all kinds of regulatory requirements that exist that covered entities have to comply with, including for their contract pharmacy agreements. Yeah. So, it is also not true that there's no oversight for the program. To your earlier point, should we codify some of those requirements? Maybe. I think most health centers, in my experience, don't feel uncomfortable about that because they're complying already. So I think that makes some sense. And then, the last misunderstanding I can think of that I hear and I see in the media sometimes is that 340B is costing taxpayers or the government money, right? I mean, that is patently untrue. The only entities directly financially impacted by the program are drug manufacturers and covered entities. If the program operates as it has been, or had been, I guess maybe before 2020, the beneficiary of the savings are the covered entities. And between 2020 and 2025, there has been a steady campaign to shift that savings from the covered entities, where it is legally required to be, to the manufacturers. And that is not going to result in a savings to taxpayers or the government, because it's not a program that financially is impacted, by the government. It's only financially impacted by the manufacturers and the covered entities.
Yeah, I think that's been that one. You saw me roll my eyes because that one gets under my skin big time, because it's the beauty of the program, to be honest with you, is that it doesn't actually require taxpayer dollars. And there's, that cuts both ways in terms of whether or not policymakers have the political will to take it on, because, there's politics behind it, obviously. But, I hope that we're making progress on some of the misunderstandings that you just walked through, that these are just nonsensical, and it's unfortunate, because I think the narrative to your point about what's happening in Ohio, and sort of these dark money campaigns where it's like, okay, well, what's peel back the onion? Where is this coming from, and who stands to benefit, from the things that are being said? And it certainly isn't health centers, and it certainly isn't the patients they're serving. That's the other thing that I think doesn't get talked about enough, is that, okay, if you reform the program, or whether it's the rebate model or it's reform, but depending on how it's handled, there is going to be a direct patient impact, be in the shape of loss of services, dialing back access, because there's not going to be some financial solvency to be able to support it any longer. And I think, again, I don't know that that's always, the dots are not being connected by the policymakers that are considering some of these things, where, that one I will say, sometimes there's good intentions behind, okay, let's try this, or let's try to detangle these things, which is great. And also, have you thought about the implications and what that looks like on the ground? I think, again, I'm asking a lot of speculative questions, but I'd love for you to speak to just, what do you think Congress or HRSA is ultimately trying to solve with these changes? And in your experience and sort of where we are right now, do you think they're hitting the mark in terms of what they're trying to do?
Yeah, I think, some lawmakers are motivated by by various lobbies, right? Mm-hmm. So some lawmakers are motivated by the drug manufacturer lobby, and keeping manufacturers happy. Some lawmakers are motivated by, frankly, the hospital lobby, and probably other healthcare, provider advocacy groups as well. But when we know that hospitals are really have a loud voice as well, which is a great thing because they're oftentimes representing safety net providers, other safety net providers as well. So some lawmakers are motivated by a desire to advocate on behalf of these groups, maybe drug manufacturers or hospitals or other healthcare providers as well. So those lawmakers, I presume, are working to make changes that will make either of these two groups happy. I think some lawmakers are genuinely trying to protect covered entities because they know covered entities are essential safety net providers, and putting them out of business will disrupt healthcare delivery system, including in their districts, and frankly will result in job losses in their districts when hospitals and other health centers have to close. So, I think lawmakers, like anyone else, have different various motivations. And I believe that there are also some lawmakers, to your point, and some people at HRSA that simply believe there are not enough controls or not enough codified regulations to ensure covered entities are not misusing funds. So, I think sort of depends on which, particular lawmaker or policymaker we're looking at to understand what their motivation is. Are they hitting the mark? I think parts of federal legislation have begun to thread the needle of codifying regulations that regulate covered entities while still allowing the covered entities to conduct business as they have been for the last 30 plus years. So I think I personally am not of the opinion that every draft bill at the federal level is garbage. I think there are components of some of the pieces of legislation that are threading that needle between codifying regulations, but permitting the covered entities to continue to do business in a way that makes sense to them and is, not administratively burdensome. I think covered entities are willing to abide by most of the reasonable regulations because, as we talked about, they already are in many instances. The problem is that the manufacturers, in my opinion, have not demonstrated that they're willing to negotiate in a meaningful way, which I think is why the various legislative efforts have stalled. I mean, you really have two camps that are at odds as to how the program itself should be operated. And you've got lawmakers and policymakers, I think, squarely in one of these camps. Then you've got those in the middle that are really trying to broker a deal. I think covered entities have moved more toward the center than the manufacturers have. Yeah. But I think that until we get some reasonable legislation that falls somewhere in the middle, we're probably not going to make any progress.
Well, I'll just make a plug for 340C, honestly, because I do feel like 340C finds itself in the middle in that way, in that it's completely opt-in. And so it's sort of it's in the sense that, okay, if you don't want to participate, then continue on your way with the program as it exists now, and with whatever consequences are to come in terms of manufacturer changes and otherwise. But if you opt in, and in exchange for the accountability and the transparency, then you have the guardrails and the protections and the guarantees, which I think that is the middle, and it's an oversimplification, but I do, I hope that we're moving in the direction, and we saw some positive movement in terms of elements of 340C being pulled out for, sustain and other actions. And I think that there's still opportunity to do more work in that space. But I agree with you in terms of more and more, I think on the entity side, there is this sort of movement toward the middle. I'm hoping that maybe at some point we'll see the other side follow suit. I think right now with the rebate model, there's a lot of conversation and projections about this is what it could mean, this is what we're anticipating, but there have been some changes that have occurred already that are already taking effect operationally. So can you speak to that a little bit?
Yeah, I think probably the most significant is reduced access for patients in certain areas where covered entities are restricted on their contract pharmacies. I have a health center client in rural Ohio that does not have an in-house pharmacy, that relies on big pharmacy chains as their contract pharmacies, and are have been have seen reduction in access because they can't continue to use their network of pharmacies in that really large, geographically large area that also doesn't have great access to infrastructure. So patient access is a real thing that is happening, that has been happening. Lost revenue, of course, is happening because when a covered entity isn't able to use the contract pharmacies it's been using, then the number of scripts that patients are using that otherwise would have resulted in some 340B savings are going away. So certainly lost revenue and reduced patient access. Your point is well taken. I think some of these other, and they have already begun to see a financial strain due to the infrastructure they have had to develop within their health center in order to participate in the program. That is costly, and that's an ongoing expense. So I think, the impact to their bottom line in that way as well. I imagine that the rebate model will certainly result in pretty significant additional loss of revenue. And again, the administrative burden of just following, on that new pathway, following the scripts that are eligible for the rebate and following up. I think that the rebate's supposed to be paid within 10 days or something like that. And if it's not paid within 10 days, then, of course, then the covered entity to engage in this process, try to get the rebate paid. It's going to, so I work in healthcare for a living. You work in healthcare for a living. We see how these systems work, even when they're functioning as well as they're supposed to. They're powered by people and computers, and so there is always a delay. There is always, there are always claims that are not getting paid. It's just the way it is, and the people power required to stay on top of these things is significant. So it's just this growing burden on the covered entities.
Yeah. Well, and I think, last couple of questions here, I think to that end, I'm biting my tongue a little bit, which is unusual for me. But I think that there are certain services that are likely to take a hit, first as health centers and others are being forced to, make difficult decisions. But from your perspective and sort of what you've seen so far, are there specific types of patient services that are kind of most likely to fall back in this unfortunate sort of circumstance?
Yeah, I think, services that are not considered necessary or that don't generate, significant revenue, or soft services like case management, which obviously are incredibly important, but, may not be considered necessary, are probably the ones that will take a hit first, or that do oftentimes take a hit first. I think the ability of covered entities to offer prescription access programs as robustly as they had historically, as those programs are at stake as well. It's just, kind of the nature of the beast when your revenue shrinks and you are using that revenue to offset losses for your patients, that the opportunity to do that shrinks a bit. So I think those kinds of programs are, and then other programs that are, so important to care delivery, but again, that health centers may have added by using their savings are probably the first that will go away. So transportation, supportive services to ensure that people can get care, those will probably go away as well.
Yeah, I hear maternal health services a lot too, which is really sad, but also a little scary, particularly in rural areas where there is already a maternal health desert. So it's sort of like, okay, so the health center or, covered entity is literally the only one in the area for wide service area providing those services. And it's either a loss leader or they just can't, it's not sustainable. And so that's unfortunately. And so then it's like, well, what happens? What happens to those communities? What happens to those patients?
I think that's a great example of a way in which the safety net safety net providers kind of support each other. So, lots of hospitals, particularly rural hospitals, have been getting out of the maternal health game, and federally qualified health centers have picked that up, which is, a great opportunity for those two types of safety net providers to work together. But to your point, yeah, it's a very expensive service. It's a risky service. So it's a tough service to deliver. So to your point, we're already seeing that sort of, contraction. And if that continues, who will provide that service?
Well, that's right. And it's sort of like, that's not just a health center problem. I mean, the health centers that is a service that health centers, I hear, are dialing back because they just don't, the 340B dollars are allowing them to do it. But I also, to your point, I hear probably once every other week about a hospital partner who is moving out of that space and looking to partner with the health center to pick it up.
Yeah,
so,
for sure.
There's a lot of immediate challenges, but then the challenge is exponentially greater down the line if we are not careful about what it looks like. And, you see that in this space. I see it, and I think about it a lot when it comes to workforce. But sort of a final question for you. Well, actually, two pieces. Are there specific data points or sort of stories that you have found to be most persuasive in sort of having these conversations with policymakers and advocacy work? And then the other piece is that, given that you work with both health centers and Ryan White clinics, what insights do you give about the broader healthcare ecosystem and how it will fare in the next few years? Sort of bigger picture of like what this looks like, getting at what we were just talking about, sort of like there's the immediate issue now, but what does this look like, sort of longer term?
Yeah. So I guess to answer your first question, what stories or data points are most persuasive? I mean, I think it's imperative for covered entities to quantify their savings.
Yep.
That's sort of, I think, the threshold, and many health centers are not comfortable doing that, or historically have not been comfortable doing that. I think we need to get comfortable with quantifying our savings and drawing a clear line between the savings and what services those savings are providing. And, it might not be a new service. It could be a new population or a new location, same service, broader population, could be a new service. I think quantifying the savings is a necessary first step, and then being clear about what that savings is doing for a particular community. And, when a health center has a legislator visit, right, it's a great opportunity to say, in your district, we've been able to serve, 500 more patients this year because of our savings, because we, we're able to, invest in a mobile clinic or whatever it is. But being really clear and concrete about what the savings means for that health center is important. And honestly, I think covered entities should not be ashamed of operating a healthy, compliant 340B program. Covered entities did not invent the 340B program, but here we are, right? We live in this environment where it is the fabric, or it's part of the fabric of the healthcare financing system. And if the health center is operating a compliant 340B program and it is doing what it's supposed to do, which is generate savings, we should not be ashamed to talk about that. What insights, so to your last question, I guess, what insights do I have sort of through my work representing health centers and Ryan White clinics about the broader healthcare ecosystem? I mean, I think providers already have kind of battened down the hatches. They're just getting really, frankly, kind of hardened about how to operate in this incredibly difficult environment resulting from policy changes at the federal and in many cases the state level. They're asking the right questions. They ask questions of me every day about, how to help them navigate what genuinely seems now to be a significant policy changes every day or every week. So I think providers generally have already come to terms with the fact that this year and the foreseeable future are going to be really hard. It's just going to be hard. It will mean being able to serve fewer people with less money and fewer services. I think it's forcing providers to collaborate. I think it is forcing, in some cases, providers to consolidate. to come together in order to serve a population, to share ideas, to share best practices, to invest in compliance. And I think there should be a renewed sense of urgency about the need to advocate at the state and federal levels. I mean, I'm a huge proponent of healthcare trade associations, including PCAs. I think, we have a really great PCA in Ohio, really active. I would certainly encourage health centers to participate in whatever trade association they are a member of, to leverage their collective power with policymakers. But I think they have already sort of begun to dig in and realize that it's just going to be really tough for the next couple of years.
Well, you said some things to kind of bring us around on a higher note. We're definitely in the middle of a storm, and this, 340B, unfortunately, is not the only storm that we're in the midst of. But health centers are incredibly resilient. I do think this one and some of the other challenges we face are different. Like, I don't know that resilience is going to be enough, but I do appreciate what you just said in terms of coming together, and I don't think consolidation is a bad thing, or it doesn't have to be, and I think working together in order to optimize and make more efficient. And, those are things that I think that's a positive that we can lean into in order to come through this. But also I think just to get better in general. And I also appreciate you bringing up, the importance and the need for advocacy and leaning into different trade associations. Like I said, I'm really, really proud of the work that ACH has done, and our team in particular in terms of what we've done with 340C, but a lot of, an array of advocacy on 340B in general. But that's been in concert with the PCAs. That's been in concert with, folks like Colleen Myman and Steve Carey and yourself. I think the work that you're doing is really, really valuable and incredibly important as well. And so I appreciate it. I'm sure if you're open to it, we'd like to have you back, because there's going to be more on this topic. This is, will continue to unfold. And I think there's so much more to discuss and to learn and to share. But honestly, Daphne, I can't thank you enough for joining us on Community Health Centers Unfiltered. And for those of you that were able to join us today live, we're so glad to have you. We hope that we'll see you on the next conversation. If you enjoyed the conversation, please consider subscribing and sharing this with your colleagues in your network. Thanks for tuning into this episode of Community Health Centers Unfiltered. A big thank you to Daphne Kackloudis for sharing her insights on the 340B program and the real-world impact of new federal rules. If you found this episode helpful, subscribe, leave a review, and share it with colleagues who care about community-based healthcare. I'm Amanda Pears Kelly, and we'll see you next time on Community Health Centers Unfiltered.